Okay.
Okay.
Yeah.
Okay, good day, everyone. We are on our 13th session of Learning Basic Arthroscopy series of lectures. So today we have an important topic, that is graft harvest choices for ligament reconstruction. This is something which has to be given a lot of attention because at least at one point of time, everyone would have gone through a situation when our planned graft has not turned up very well, either in length or thickness, or the patient also has an additional ligament injury that you need an extra graft. More so in multi-ligament knee injuries where you need multiple graft options. So Dr. Sandeep Nema is there with us. He is Associate Professor of Orthopedics from JIPMER from Pondicherry, India. He is going to give us the lecture on graft harvest choices. We also have Dr. Raghavan Sivaram from Apollo Hospital, Muscat, my colleague. Welcome, Dr. Sandeep and Dr. Raghavan. And myself, Dr. Saseendar, and Dr. Srinivas from Vijayawada. So welcome, Dr. Sandeep. Please go ahead.
Yeah, thank you, Dr. Shashindar. This is Dr. Sandeep Nema. I'm working as Associate Professor in Orthopedic Surgery at JIPMER, Pondicherry. And special interests includes arthroscopy and sports medicine. And I'm going to share the screen. So, yeah. You can see the screen?
Yeah.
Yeah, okay. So, in half an hour or so, we are going to discuss about graft choices, not only in anterior cruciate ligament reconstruction, but ligament reconstructions in general around the knee. So, these graft choices we are going to discuss in short, either in isolation for ACL or for the multiligamentous injuries around the knee. So basically, I have divided this talk into three sections. The first section is introduction in general about what are the graft choices which are available. Section 2 includes the evidence which is in favor of which graft and what is the latest available evidence with us. And section 3 includes some of the basic techniques in graft harvest of commonly used graft choices like bone patellar tendon bone or the hamstring tendon. So without wasting much time, we start with the introduction. So what is actually an ideal graft for ACL reconstruction, if you say? So the graft should be easy and reproducible to harvest. I will say reproducible, I will stress more because most of the surgeons around the world, they are in the beginning of the career, in the mid of the career, and so for them, this reproducible word is more important. It should be sufficient in length and diameter. As we all know, the grafts lesser than 8 millimeter of diameter tend to fail. So there should be adequate diameter to the graft. Then it should be of sufficient length so that at least 15 millimeter to 20 millimeter of graft comes in both the tunnels, one in each of the tunnel, which is that is the tibial tunnel and the femoral tunnel, and we get sufficient graft into the joint. Then there should be minimum donor site morbidity. Okay, we are going to discuss them about as well. Then it should be strong. It should approximate biomechanical properties of the native ACL. Okay. Then there should be faster incorporation within the bone tunnels and ligamentization. It should not interfere with the rehabilitation protocol. It should be free from risk of rejection or disease transmission. It should be cost effective and should be readily available. And regeneration, these days, a few of the studies have come up which document regeneration of the graft from the donor site of the hamstrings, bone patellar tendon bone. And we also have conducted a study on regeneration of quadriceps tendon. What are the changes that occur at the quadriceps tendon donor site? So we're going to discuss in short about that. Actually, the ideal graft and the gold standard does not exist. If we go through different grafts, the one or the other graft lacks in one or the other things. So what are the graft choices that are available to us? So we have the autografts. We know these are the bone patellar tendon bone. the hamstrings, the quadriceps tendon with or without bone, peroneus longus tendon, and facial lata. For allografts, we have wide variety of options. These include tendoachilles, tibialis anterior, tibialis posterior. Then we have the graft substitutes, which includes the scaffold, stents, and prosthesis, and primary repair in case of avulsions from the femoral and the tibial side. So when we talk about hamstrings, they can be semitendinosus alone or semitendinosus with gracilis, or it can be quadrupled, it can be pentavalent. The graft, but the basic basic thing which is important is it should not be less than 8 millimeters, because a diameter less than 8 millimeters is associated with more failure rates. Then we have the bone patellar tendon bone. In the bone patellar tendon bone also we have a lot of variations. It can be bone plugs on both the sides. It can be bone plug on one side. Then this graft is gold standard so far because it has stood the test of time. But there is an increased risk of radiographic osteoarthritis, which we are going to discuss, which is associated with this graft. Then the quadriceps tendon. This tendon is revisited every decade or every 5 years. And every 5 years, you'll find out evidence and literature supporting the use of this graft. Then the peroneus longus tendon. This tendon has come up these days, and more use with this of this graft has been reported. When we talk about the quadriceps tendon and the peroneus longus tendon, these are the two autografts which consistently give you a diameter of more than 8 millimeter. These are the two grafts. And then the facial lata graft, which is implant free, but it is not in use anymore. So we won't be discussing about facial lata graft. This is a table basically which shows the comparison of biomechanical properties of different grafts. So if you see the patellar tendon, quadrupled semitendinosus and gracilis, quadriceps tendon, all of them approximate, or they are biomechanically, they have a more tensile strength and stiffness compared to that of the native ACL. Okay. There may be differences in incorporation of these grafts, obviously, which we are going to discuss. When we talk about the hamstring tendon, the advantages which are associated with this graft is high load to failure. It has a greater cross-sectional area. It is easy to pass, associated with less donor site morbidity, smaller incision, but again, there is a problem of bungee effect. And it has a slow bone to tendon healing compared to that of the bone patellar tendon bone graft. There is flexion weakness, and there is injury to the saphenous nerve. Okay, so these are the advantages and disadvantages in brief. I think most of you know about the advantages and disadvantages of the hamstring tendon. When we talk about the bone patellar tendon bone graft, the advantages are, again, the load to failure we have discussed. There is faster bone to bone incorporation or bone to bone healing. So therefore, this is the preferred graft as far as the athletes are concerned. Then it has a better functional outcome scores and objective arthrometer testing than any other graft. So that's why this graft is, I will say, it is a gold standard to compare the outcomes of the other grafts. The disadvantages associated with this graft is patellar fracture, anterior knee pain, anterior knee numbness, and residual quadriceps muscle weakness and extension weakness. I'll say it is more difficult to harvest this graft compared to that of other grafts. Now we come to section 2, that is what is the evidence which we have for various grafts. What is the evidence which is available for anterior cruciate ligament reconstruction for these graft choices. First we discuss about bone patellar tendon bone versus hamstrings. So in the coming 4 slides, I'll discuss about what is the latest evidence available when we compare these two grafts, the failure rates, the success rates, the outcome test, the functional and objective outcomes. If we see every year, or if we see the evidence, you'll find a lot of systematic reviews, not only systematic reviews, but now the long-standing randomized control trials of 17 years to 20 years comparing the efficacy of both these grafts. So the first one which I would like to discuss, which is more reliable is the one from the Cochrane database of systematic reviews. So this review actually assessed 19 trials providing outcome data of 1,597 young to middle-aged adults, and they compared the hamstring tendon versus the patellar tendon. And they found there was no difference in objective and subjective outcomes between hamstring tendon and patellar tendon autograft. While the patellar tendon reconstructions are more likely to result in statistically stable knees, they are also associated with more anterior knee problems. Another one, this was published in the Knee, the meta-analysis of bone patellar tendon bone autograft versus 4-stranded hamstring tendon autograft for anterior cruciate ligament reconstruction. So they concluded that bone patellar tendon bone is superior to hamstrings in resuming rotational stability of the knee joint and allows patients to return to higher levels of activity in comparison with 4-stranded hamstring tendon autograft. Whereas the post-operative complications of the knee joint were lower for 4-stranded hamstrings. So they concluded that there was insufficient evidence to identify which of the two types of grafts are significantly better. I think the next one, which is published in the clinical orthopedic and related research, this is most interesting one, and this is what is more clinically relevant to us because it gives the number needed to treat for failure. So again, the systematic review assessed the hamstrings autograft versus the patellar tendon autograft for ACL reconstruction. And is there a difference in graft failure rates? So it was a meta-analysis comprising of 47,613 patients. And the purpose of the systematic review was which graft type of ACL reconstruction was at a higher risk of graft rupture and graft laxity. And what they come up is 235 patients would need to be treated with bone patellar tendon bone graft over a hamstring tendon graft to prevent one graft rupture. That is the number needed to treat. So you can see the difference is really very minimal. It's very minimal. Then, as far as the instrumented laxity and pivot shift testing and Lachman testing is concerned, that is given over there. There is very minimal difference between the two. Then, we have a 17-year-old follow-up of or randomized controlled trial comparing semitendinosus and gracilis tendon versus patellar tendon autograft for anterior cruciate ligament reconstruction. This was published in 2018. And what they found is that there is no statistically significant difference with respect to graft failure and functional outcome between the two grafts. There is increased laxity measurements with KT1000 arthrometer more in patients with semitendinosus and gracilis group. And a significant difference was found in frequency of knee osteoarthritis, 100% versus 70%, 71% in patellar tendon versus the STG group. And the patients in PT group, patellar tendon group, tended to have a higher grade osteoarthritis according to IKDC grading system. So the degenerative changes in the PT group were more common in medial and patellofemoral compartments. What I feel is that when we talk about this evidence, it is not this evidence, it shows very minimal difference between the two grafts. But instead of that, I will say that there are very different factors which influence our graft choice. So let us see what are these factors which will influence my or your graft choice selection when we do a ligamentous reconstruction. So these include the age. Generally, patients who are athletes, younger age group, there is a tendency for use of the bone patellar tendon bone graft in these group of patients. And the reasons are obvious. There is faster incorporation, it has stood the test of time, and the laxity measurements are less compared to that of the hamstrings graft. Second is occupation. Obviously, the bone patellar tendon bone graft will be a graft of choice for young athletes who want to return back to sports, okay, because of the earlier faster incorporation. Then associated injuries. If there is a posterolateral corner injury, definitely one would tend to use a semitendinosus graft over there and may elect to reconstruct the bone patellar tendon bone graft with may elect to reconstruct the ACL reconstruction or ACL reconstruction with the bone patellar tendon bone graft. So it depends upon what are the injuries, associated soft tissue injuries which one has sustained. Then Patient requirements. These days, many patients come up, they see what is the available evidence, and they themselves suggest the graft choices in them. Then the type of injury. What is the type of injury? Whether it is a intra-substance tear or it is a avulsion, that also dictates, because of more tendency for repair, or more evidence coming in favor of repair from the femoral sided avulsions. So it really depends. As far as the avulsion from the knee, from the tibia is concerned, that all of us will agree that will repair. Okay. Then the type of fixation devices. See, if you will, I am really uncomfortable with the screws. So it really depends upon the training of the surgeon, what he wants to use. So I will go in for a soft tissue graft or a semitendinosus and gracilis graft because I like suspensory fixation. It is easy. Whereas on the other hand, the surgeon who is trained with bone patellar tendon bone graft may elect the screws. Okay, he may be choosing the other way. Then revision ACL. If there is a ACL reconstruction which has failed and earlier the graft used was semitendinosus, then you have an option of bone patellar tendon bone graft. Then availability, say multiligamentous injury of the knee or revision ACLs, what is available to you? Then training, how one is trained. So another thing is that is what is the there is a study which looked into the factors affecting patient selection of graft type in anti-cruciate ligament reconstruction. So this study, if you see the point number 10, I have taken out the conclusion of the study. That is, much of the graft choice depends upon, in order of preference, if you'll say, from what the physician recommends, what the coach recommends, then family and friends, media, recovery time, and disease transmission. So these factors, there's a study specifically looked, and they come up with these factors which influence the graft choices as far as the bone patellar tendon bone and or the graft choices in ACL reconstruction in general is concerned. Then what are the other autograft options besides bone patellar tendon bone and hamstrings? So these are three. We are going to discuss in short about them. The first one is the quadriceps tendon. The second one is the peroneus longus tendon and the fascia lata. We are not going to discuss fascia lata because not much in use. So as far as the quadriceps tendon is concerned, this tendon or this autograft has been looked from time to time, and now we have a good level evidence coming in form of randomized controlled trials and meta-analysis, which have compared quadriceps tendon with the hamstrings, which have compared it with the bone patellar tendon bone. So let us see what are the outcomes from these meta-analysis and these studies. So what is the evidence in favor of anatomy, histology, biomechanical properties, clinical outcomes, and donor site mobility in QT? So anatomically, quadriceps tendon is a laminar structure with an average width of 27 millimeter, thickness of 8 millimeter, and variable length up to 7 to 8 centimeters. And histologically, quadriceps tendon is 1.8 times thicker than the patellar tendon. It has a higher fibril interstitium ratio and higher fibroblast density. It has 20% more collagen than the patellar tendon. Then what is the evidence on instrument laxity measurements, Lachman test, pivot shift test, and outcome scores? So on comparison, see, these are the two systematic reviews which I have found out. One is, one was published in 2015, another one was published in 2019. The first review compared quadriceps tendon 383 versus bone patellar tendon bone 484. And the second review assessed 581 quadriceps tendon versus 514 bone patellar tendon bone, 181 quadriceps tendon versus 176 hamstrings tendon autograft. And they found out that there is no statistical difference in both the reviews and comparable graft survivals. Then there is lesser donor site morbidity in quadriceps tendon ACL reconstructions. QT autografts has less pivot shift laxity and lower failure rates based on final subject number than hamstring tendon autograft. Then when we talk about the fixation devices, compression quadriceps tendon autograft femoral fixation had lower pivot shift laxity than suspensory hamstring tendon autograft femoral fixation. Compression quadriceps tendon autograft femoral fixation had less anterior knee laxity and lower failure rates than compression HT autograft femoral fixation. Then what is the best available evidence on patients undergoing ACLR with partial thickness and full thickness quadriceps tendon autograft? Because the quadriceps tendon, in our experience, it's uniformly you'll get a diameter more than 8. So one has an option of doing harvesting the graft, which is either full thickness or partial thickness. So there is no difference in outcomes or complications between partial thickness quadriceps tendon or full thickness quadriceps tendon in primary ACLR. Moreover, primary ACLR using quadriceps tendon autograft appears to have successful outcome with low rate of graft failure and irrespective of tendon thickness. Then, this is in short our experience. Actually, we conducted a study and we assessed the ultrasonographic changes at the quadriceps tendon donor site, because the regeneration in semitendinosus tendon and hamstrings and patellar tendon has been documented. Though the quality of regenerate, there is a debate over the quality of regenerate, whether it can be used, cannot be used. So during this study, we had some of the experience with the quadriceps tendon. So the first and foremost is this graft length, the patient's height influences the length of this graft. So the taller the patient, the longer the graft. This is similar to that of the semitendinosus tendon. Then free quadriceps tendon you may get insufficient length. In the group which we have studied, we got insufficient length, and therefore we recommend harvesting the patellar bone along with the quadriceps tendon. So average length which we saw was 5 centimeter in 5 to 6 centimeter in females and 6 to 7 centimeters in males. So there will be a little bit of struggle. Then the routine MRI sequences for ACL, we recommend that in routine MRI sequences which you use for imaging the ACL test, include full length of the quadriceps tendon to plan its harvest before operation. That's what we will say. Then you while harvesting, you err on the lateral side for the harvest of the graft, because there you will get the full length of the tendon. And routinely you will have two identifiable bundles which are separated with a layer of fat, and it can serve as an excellent autograft for inlay PCL reconstruction. We have done a couple of them, and then our experience is very good. And because the thickness of this graft, unlike the bone patellar tendon bone graft, which has also been recommended, not used much for the PCL reconstruction, so compared to that, you'll have, and compared to the 4-stranded semitendinosus graft where you may have length issues, compared to these two, you will have a uniform thickness and uniform length of this graft. But obviously, you will have to routinely image the tendon, and then you will have to find out its length, and then subsequently you can plan it. Okay. So so this is in short our experience about the quadriceps tendon. The next one, the peroneus longus tendon. So the advantages with both the peroneus longus tendon and the quadriceps tendon is the uniform thickness. I will stress again the uniform thickness which is with these grafts. So when we talk about peroneus longus tendon, what is the evidence which is available to us? So the first and foremost is biomechanical properties of peroneus longus graft. Are they consistent with ACL? So we talk about the tensile strength. It has a 4,268 newtons of tensile strength, and it has a 13.36 mm of deformation. Then what are the outcomes after ACL with ACL reconstruction with peroneus longus grafts? So these are the two studies which we saw. One is a 2-year follow-up study, and another one published in 2019. The second one published in 2018. And they came out with the IKDC modified Cincinnati and scores recorded preoperatively and 1 year after surgery revealed comparable outcomes to that of the hamstrings autograft with the advantage of larger graft diameter and less thigh atrophy. And there is no significant difference between the hamstring tendon and peroneus longus graft at a mean of 30 months on objective and subjective testing between the two groups in the RCT, the lower one. Then obviously there is a concern about the function of the foot after the harvest of this graft. So this study specifically looked into the plantar flexion weakness or effects on eversion and first ray dorsiflexion strength between the donor site and the normal site, then American Orthopedic Foot and Ankle Society scores and foot and ankle disability scores among patients where the peroneus longus tendon was harvested for the purpose of reconstruction. So they found that the ankle eversion and first ray plantar flexion strength at the donor site were similar to those at the contralateral healthy site with no donor site morbidity. Excellent AOFAS and foot and ankle disability scores were found in those patients. Then, in short, about allografts. So, what is the evidence which is available for us for allograft? Allografts offer benefit of no associated donor site morbidity, shorter operative time, greater selection of graft dimensions to suit the desired recipient site in bony and ligamentous reconstructions. However, allograft tissues have inferior biomechanical properties, higher rates of reoperation, risk of immune reaction and rejection, and risk of disease. I will say the allografts are more useful in multiligamentous reconstruction of the knee, where you have, say, knee dislocations, where one or two or three ligaments are involved, where you may have limited choices and considerable donor site morbidity if you use the autograft. So allografts particularly find a place in those situations. So these are the popular choices: the tibialis anterior, tibialis posterior, the tibia tendoachilles. So when we compare allografts versus the autografts for ACL, what we see that this particular meta-analysis of randomized controlled trials and systematic review of overlapping systematic reviews, this was published in Arthroscopy 2016. And they looked into allograft versus autograft for ACL reconstruction. There were 9 randomized controlled trials and 10 systematic reviews in this review. And the autograft, they found out that autograft had greater advantages than irradiated allografts with respect to function and stability. And there is no significant difference between autografts and non-irradiated allografts. I'll say this difference, you understand, the irradiation of the allograft decreases its tensile strength considerably. So there is no significant difference between autograft and non-irradiated allografts, but autografts had greater advantages than irradiated allografts. Another study which I'll say here, that is no statistically significant difference were detected between autografts and non-chemically processed, non-irradiated allografts in functional outcome scores and objective arthrometer testing. Okay, and or failure rates between the autografts and the allografts, particularly non-chemically processed, non-irradiated allografts. Then besides that, there are certain factors that influence the biomechanical properties of allograft tissue for ACL reconstruction. What are these factors? These factors are the graft type. If you see the load to failure, it is lowest in non-looped tibialis anterior and tibialis posterior tendons and highest in looped tibialis anterior and tibialis posterior allografts. There's lowest stiffness in non-looped tibialis anterior and tibialis posterior and highest in quadriceps tendon grafts. Then irradiation, higher dose of irradiation consistently produces decreased load to failure and stiffness. Chemical sterilization, various chemical sterilization measures were also associated with negative effects on biomechanical properties. Then preservation methods, prolonged freezing and decreases the load to failure, ultimate stress and ultimate strain, and up to 8 freeze and thaw cycles did not lead to difference in biomechanical properties of cadaveric grafts. Donor parameters, gender as such has no difference, no effect on graft properties. Then increasing age and has a negative correlation with the mechanical properties of allografts. Donors older than 65 years of age had ultimate stress values that were 61% of that of the patients between 15 to 40 years and 68% to that of ages 41 to 65 years. Then graft preparation. The central third of patellar tendon is biomechanically stronger than the medial third and the lateral third. Looped tibialis anterior has tibialis graft has a 75 to 100% increase in load to failure relative to non-looped graft, and longitudinally splitting a tibialis and a tendo-Achilles allograft for double bundle ACL reconstruction showed no difference in stiffness compared to that of the intact graft. And hamstring graft ranging from 6 to 9 millimeter in diameter, the load to failure was increased. For 7 mm, it was 138% of 6 mm. For 8 mm, it was 166%. And for 9 mm, it was 285% of the 6 mm graft. For 4 to 4.5 mm and 8 to 9 mm BPTP graft, the maximum load was 93% higher in the wider graft group. Then in short about graft substitutes. So what are scaffold, stents and prostheses, and what is the available evidence? So if we talk about scaffold, it is made up of a synthetic tissue, mostly carbon fiber, and stimulates growth of fibrous tissue. But the problem is synovitis, lack of growth, and failed adhesion to the bone tunnels. What is a stent? So the Kennedy ligament augmentation device is the prototype of it, and it is designed to protect the healing of a biologic graft during incorporation phase in the joint. But again, the problems associated with it are infection, synovitis, and effusion. Then prosthesis is made up of Gore-Tex or polyethylene substitutes, and the biologic graft. But again, the problems are chronic instability and joint effusion. So Batty et al., they have done a systematic review and they compared ligament augmentation reconstruction system, LAD, and different devices. And what they come up, these include the Gore-Tex and the Dacron and the ligament augmentation device. They compared different substitutes, and they come up that the heterogeneity of the included studies precluded the meta-analysis first and all. And there was lowest cumulative rates of failure with the newer generation of Lars device, 2.6% for ACL and 1% for PCL surgery. The highest failure rates were seen in Dacron ACL group, that is 3.6%. And they concluded that the preliminary results for new generation devices, specifically Lars, show a lower reported rates of failure, revision, and sterile effusion. This is a table which essentially emphasizes the same. Then this is the latest, the 30-year follow-up study which was published in Journal of Bone and Joint Surgery. And the study essentially compared the autologous bone patellar tendon bone ACL reconstruction with ACL repair and synthetic augmentation. And it is a 30-year follow-up. So the RCT group studied were repair, reconstruction with bone patellar tendon bone, and acute repair with ligament augmentation device. So the main finding of this 30-year follow-up study was that the number of ACL revisions was significantly higher in primary repair group and in ligament augmentation device group than in bone patellar tendon bone group. But we understand that since the newer generation of ligament augmentation devices have come up, and this is a 30-year follow-up study, we expect that in due course of times the findings are going to change in favor of ligament augmentation device. Then now this is the section 3 and the last section of my talk, where I'm going to discuss about the preoperative consideration, harvest methods, and pitfalls which are associated with autografts. So when we talk about the hamstring stent, and I will directly jump upon the method, and before going on the video streaming, what I would like to emphasize for those who are beginners as far as this graft is concerned, you see, you need to understand for harvesting this graft successfully, you need to understand the 3 layers of the semimembranosus fascia. So if you understand 3 layers of the semimembranosus fascia, you won't have any problems in harvesting this graft. Second thing is, you need to understand that this graft may have up to 8 connections or accessory semitendinosus, which may lead to premature amputation of this graft. That is the second issue which you need to know. Okay, so we'll directly move on on the video, what I do basically is that I roll the tendons by thumb against the subcutaneous border of the tibia. Then I give a vertical incision directly over the tendons cheating proximally. After dissection of the subcutaneous fat and first layer of semimembranosus fascia, the tendons are again rolled. And remember that the tendons that are easily palpable is the gracilis. So gracilis is more easily palpable than the semitendinosus. It is proximal of the two. And then I give a sharp incision in an inverted L fashion. I identify the tendon and isolate them. How do you identify the gracilis? Because this is the main problem, identification of gracilis and semitendinosus per operative. How do you identify? There are a few tricks. It is easy to palpate, it is superior to semitendinosus, and it has undulations on its surface, and it is thinner in diameter. Then I do the identification of accessories semitendinosus. I resect it, and as I said, variations in anatomy of semitendinosus have been, and all three, in fact, semitendinosus, gracilis, and sartorius has been documented. So you need to keep that in mind. And then subsequently, after harvesting, I mount it with the fixation device. Another very important trick which I would like to say is that how do you know that you have adequately released the semitendinosus tendon for passing the tendon stripper? This I will highlight in the video again. So let us see. So this is the incision. Then subsequently, after giving the incision, I roll the tendon. That's how I'm rolling the tendon. After rolling the tendon, then I'll give an inverted L incision. Remember, this is a very thin layer of fascia, so don't go too deep. And then on the undersurface of this first layer, you will see the tendons. Then you deliver them with the help of a right-angled clamp. And then subsequently, you identify the accessory semity. There I identified. You release it further. And release the accessory semity. I think I showed the semity. And then you release it with the, and then that's what I'll wait just a minute. I'll go back. And then yes, this is an important test. What we do is that by pulling the semity, we cross it to the opposite border of the tibia, subcutaneous border of the tibia. If the semitendinosus can be pulled across the border of the tibia, we consider that we have released the semitendinosus sufficient, and then we can pass on the tendon stripper. Okay, so just hold on. And then this is the release of the tendon. And then I would like to take the periosteum along with the tendon because it helps in healing. Then we release the muscle belly, and then a consistent length of 28 millimeter. If that is identified, then definitely you can quadruple the semitendinosus, else you will have to harvest the gracilis as well. This is mounting on the device. So that's how we mount it on the device and make a 4-stranded semitendinosus graft, passing it through a fixed loop device or the tightrope, and then suture it. And then we mark according to the depth which we measure for the femoral tunnel and mount it. And then we give a tension to the device and measure its diameter. So this is in short about the semitendinosus tendon. Then what about the bone patella tendon bone graft? This is more tricky compared to that of the semitendinosus tendon. So you need to be more careful. I do not do it regularly. Rather, in the demonstration, my colleague Dr. Gopi Shankar, he will be demonstrating the how to harvest the bone patella tendon bone graft. I do not do it regularly. So there are few preoperative considerations and pitfalls with this graft. What is that? You do not, this is not the graft of choice in case if there are patellar disorders or if there is a tendinitis of the patellar tendon, or in immature patients, or if the height is less than 5 by 4. And then you need to take into consideration patella alta, then graft tunnel mismatch. How do you correct the graft tunnel mismatch? I'll talk about that. That is, if it is less than, if the tibial bone plug is protruding less than 5 to 10 millimeter, then you can avoid, no need of, you can simply trim the graft. If the bone plug can be removed, if it is more than 5 to 10, if it is protruding more than 10 millimeters, then in that case, the bone plug can be removed and it is inserted free in the tunnel. And the tendon is sutured and fixed, else the plug is discarded and the tendon is fixed by screw and post. Or the tibial trough can be prepared and fixed with the staple. Or you can recess the femoral plug for no more than 3 to 4 millimeters into the femoral tunnel. Or you can rotate or twist the graft, but not more than 180 degrees. And so this is, just a minute. Okay, so this is a short video of a minute or so, or you give he prefers to give an oblique incision, then he identifies the paratenon, he incises the paratenon. So there you can see that he is approximating the paratenon. Then he marks the tendon with the help of ink, and then sharply uses a 10 millimeter blade. Then he marks over the patellar and the tibial bone plugs. I recommend using a cautery device to mark the patellar and tibial bone plugs, because then it is easy to use the saw. Then he will bullet the femoral and the femoral plug, make 2 holes through it and measure it with the help of a device, and then close the incision. The bone which is left over or which is collected at the time of bulleting the femoral bone plug can be used for grafting the patellar bone site. Then, as far as the quadriceps tendon is concerned, so the quadriceps, few tricks with the quadriceps tendon. That's what is our experience. It is thickest next to the superior pole of the patella. The average thickness at the patellar insertion is 16 millimeter for females and 18 millimeter for males. And always one will find a thin fatty layer between the rectus femoris and the deep vastus intermedius part of the QT. Better harvest or err on harvesting the quadriceps tendon laterally. And we recommend patellar bone plug with quadriceps tendon instead of free quadriceps tendon graft because of the associated issues of length. So this is basically the commercial device. We do not have the commercial device, so our way is the traditional way of giving an incision directly over the suprapatellar region, marking the patellar tendon and harvesting it. And in order to mount the device, it can be a little bit tricky to mount the device. So that's why I have inserted a video on how to mount a tightrope device with the quadriceps tendon. This is not my video. And let's see how the graft is prepared. So basically we release the muscle attachments with the graft, and then we pass the number 2 fiber wire or some of the other suture types compatible with it, and then subsequently we take minimum of 4 loops through each end. We size the quadriceps tendon. Minimum of 4 loops are required at the end of the tendon, and then we pass the loop through the tightrope or some of the device, and then subsequently pass another 2 or 3 throws through the same end and fix it to the femoral side of the quadriceps tendon. Okay, so that's the prepared tendon. And then, in short, this is the last slide of the concluding slide of my presentation. How to harvest the peroneus longus graft. So a curved incision is taken over the posterior aspect of the lateral malleolus. You should be aware of the track of the sural nerve. Do not injure the sural nerve. So the incision should be closer to the lateral malleolus posterior border. And of the two, how to identify the peroneus longus tendon, that is also easy. From the peroneus brevis. You see, the peroneus brevis tendon is relatively muscular and fleshy. So the tendon, the tendon which is identified, which is tendinous throughout, and if you will give a pull to the peroneus longus tendon, it will be tendinous, whereas the peroneus brevis tendon will be fleshy. So this, and then subsequently you can directly pass the closed or the open tendon stripper, and the remaining stump of the peroneus longus tendon can be sutured to the peroneus brevis tendon. Thank you. So that was my last slide. And yeah, Dr. Shashinder?
Yeah, thank you very much. You can stop your share.
Yeah, yes. Yeah.
Okay, that was a wonderful presentation. You covered almost extensively on the clinical aspects of graft harvest, the evidence that is available, and also the steps towards the graft harvest, that is the hamstring and quadriceps tendon, and also the peroneus longus tendon.
Yeah.
Regarding the clinical aspects, you discussed about the options of grafts, namely the hamstring, the patellar tendon, along with bone on both sides, the quadriceps tendon with the bone plug from the patella. You also talked about the peroneal tendon, then the allograft choices. There was a lot of discussion on the tensile strength, the load to failure, which is better, doubled, quadrupled, or the quadriceps tendon, or the allograft. All the discussions were there. All were very interesting. And there is a controversy, like we have a quadrupled hamstring tendon, which has a tensile strength that is the highest, but still it is prone for some amount of laxity. That is something that the learners have to know. The
Yes.
tensile strength on table may not be equivalent to the rigidity of the graft, because
Yes.
there is a delayed stretching of the graft later. So, and the evidences that you have put up are like tremendous, and they're wonderful evidences with very good randomized control trial and meta-analysis. Thank you very much for that. So it was a wonderful presentation. We have some questions from the audience already.
Yes.
So with respect to the quadriceps tendon
Yes.
graft, what would be the choice of your fixation, both on the femoral side and the tibial side?
See, as I said in my lecture, because of our experience, we do not harvest, now we do not harvest the free quadriceps tendon because of the length issues. We harvest quadriceps tendon with the bone, with the patellar bone plug. So our fixation choice on the femoral side is a metallic interference screw, titanium screw, and on the femoral side, we go ahead with a screw and a post and a bioabsorbable screw. So you will find it a little bit interesting that I'm choosing the metallic interference screw on the femoral side and not the bioabsorbable screw, and choosing the bioabsorbable screw with a screw and a washer post on the tibia. But that's what has been our experience, because the actually the bioabsorbable screw does not absorbs or doesn't disappear in due course of time. It stays there. And going by the numerous studies and the systematic review, I am of the view that the metallic interference screw has a superior grip, superior strength, and properties compared to that of the bioabsorbable screw. On the tibial side, definitely there one may elect to do a suspensory fixation by a screw and a post, or by using a disc, or one may elect to use a bioabsorbable screw. But routinely, our practice is we use a bioabsorbable screw with a screw and a washer post. So we do two fixations.
Wonderful. Wonderful. Thank you. Dr. Raghavan, do you want to add something to this?
Yeah, the first thing is, of course, I think as he said rightly, quadriceps tendon. What we find, like me and Dr. Saseendar, we practice in Muscat in Oman, and even here we find that the quadriceps tendon per se, the length is not adequate. So unless you take it along with a bone plug, you don't get the adequate length. And majority of our patients, we normally do hamstring graft. The reason is most of our patients, because of the Islamic religion they practice, all of them want to go down to praying in the kneeling down position. And because of that, they all have a problem of anterior knee pain, especially with bone patella tendon bone graft as well. So it predominates, if you look at our practice, almost 90% of our practice, in fact, even in revision ACLs, we normally tend to take the opposite side hamstring rather than going for either bone patella tendon or for quadriceps tendon.
Okay, Dr. Sandeep, are there any studies comparing the use or not using the patella bone plug in quadriceps tendon graft?
See, as far as if you see the evidence which is available, both studies have compared. Actually, there is more or less of a comparison between quadriceps tendon with and without bone and the other graft choices. But as such, the evidence for the comparison of with plug and without or a free quadriceps tendon, I haven't come across so far. Definitely, it will be interesting to note, but I haven't seen any evidence which has directly compared the quadriceps tendon with plug versus the partial thickness or the full thickness.
Okay, Dr. Srinivas, you want to share your experience?
My practice is mainly hamstrings, quadruple hamstrings. In the UK, we used to do some bone tendon bone, but it's mainly hamstrings. Quadriceps, I haven't done much after coming here, but I think it looks, recent, looking at the recent evidence, quadriceps tendon is a useful technique to have in your armamentarium, I think.
Yeah, wonderful. And Dr. Raghavan.
Yeah, so I want to ask, of course, all the panelists and Dr. Srinivas also. See, regarding the quadriceps tendon graft, so do you normally, there are two parts of the question. First is, do you normally harvest both the both the semici and the gracilis, or only one? And the second thing is, see, in general, we know that in the Indian population, unlike the Western population, most of the people, they are not like very well built, right? So the hamstrings are not really the normal thickness, what you expect, like when you quadruple, when you get like 8.5 or 9. So when you get a little thinner hamstring, do you supplement it with using a fiber tape or something like that?
Dr. Srinivas, you'll answer. After that, I'll tell.
Well, for the hamstrings, I generally do four-strand hamstrings, and in some patients, if I'm doing, say, all inside, I tend to do just the semitendinosus, and because you can use a shorter length of the graft. Regarding the diameter of the graft, I think most of the studies that have said less than 8 millimeter diameter are international studies. I'm not sure whether we have Indian studies looking at it, because the body mass index here is lesser. I think the tendency is to accept 7.5 in India, I think, in diameter. So if the patient is well built, higher body mass index, maybe, and also demand from the knee is higher, obviously you will have to choose a thicker diameter graft.
As far as my experience is concerned, because I do mostly the semitendinosus graft, my colleague does bone patella tendon bone graft more often. What is my experience is, because this graft is relatively easy to harvest. So for the upcoming arthroscopic surgeon and those interested in sports medicine, this will be a graft of their choice most of the times, because it is easy to harvest. The morbidity associated with it is less. And so that's the reason. But a few things which are some problems which are associated with this graft is what is my experience is, that is first and foremost is you should be ready. If you will give me an option, I will go in for a quadrupled semitendinosus alone and preserve the gracilis. but that depends upon the length which I get, because the length of this semitendinosus alone, if it is more than 28 millimeters, then I will quadruple, and then subsequently 28 centimeters, then I'll quadruple it, and then I'll get a uniform thickness graft. But in many of the patients, you may not get a 28 centimeter of, in particular in the patients which we operate, we do not get a 28 centimeters of this graft. So making it quadruple is difficult. So we may have to add a semitendinosus graft. And in order to increase the diameter of the graft, I will not hesitate in combining 3 versus 2, that is tripling the semitendinosus and using double-stranded gracilis and make a diameter of 8. Then another trick which I use it is that I try to harvest the graft from the proximal side first, followed by its detachment from the tibial tuberosity, giving some 2 centimeter more of the periosteum, which is very useful in this with this graft. Obviously, there is a risk, but few, say after 50 cases, 50 hamstrings, you may get a very thin semitendinosus and gracilis, and you may not get a 8 millimeter graft. You may have to consider other graft options. As far as using an accessory augmentation device is concerned, I don't have any experience. We don't use it.
Okay, thank you. That was a very good explanation. With respect to markers, as Dr. Raghavan pointed out, we have been doing almost always the hamstring graft. In our population, we have been able to get a good length of the tendinosus. We usually don't have the gracilis, and I go with a posterior graft incision.
Yeah.
Peroneus 1 or 2 centimeter, 1.5 centimeter for pulling out the semitendinosus, and with a open stripper we can pull it out proximally, and a closed stripper from the tibia, and we do all in ACL reconstruction. This way we have been able to do a quadruple the semitendinosus graft. The good thickness, we take a minimum of 8 mm thickness. You don't compromise on 8 mm. And if it is needed, we go ahead with the gracilis graft also. As Dr. Sandeep said, either 6-strand or 5-strand semitendinosus and gracilis graft to make it a minimum of 8. We make sure we don't cross 9.5 to 10, but it is always a minimum of 8 with respect to the graft. And I tend not to add up augmentation device. Augmentation device is not a compromise on the thickness of the graft. But in case sometimes when it's a multi-ligament knee injury and you have a minimum of 7.5, then we can go ahead with tape that is held up on either side with a suspensory device. So that is an option. So we can safely say that 8 millimeter thickness of graft, either it is 4-strand or 3-strand or 5-strand or 6-strand, should be good. And good fixation is also very important. And we can quite safely say that an augmentation device cannot let you compromise on the thickness of the graft. It can add on to the stability, but not necessarily to the thickness, if as and when maximum possible. Okay, so that was a very good discussion regarding the graft choices and the thickness. Dr. Sandeep, can you summarize the thickness of the grafts that are required for various indications? For example, ACL, PCL, medial collateral ligament, lateral collateral ligament.
See, as far as the ACL is concerned, I think we have discussed enough that when you use semitendinosus graft, the thickness is, and it has to be 8 millimeter diameter. As far as the quadriceps tendon and the semitendin, the bone patellar tendon bone is concerned, to harvest the 10 millimeter of bone plug, and then subsequently that dictates the width of the tendon, but not the diameter. As far as the quadriceps tendon is concerned, it is uniformly That has been our experience, that you will get a 8 millimeter or more diameter of the tendon. This graft is particularly good if you are more worried about the diameter, because that is consistently you will get a more than 8 millimeter diameter with this graft. As far as the PCL is concerned, our graft of choice for PCL reconstruction, because most of the PCL reconstruction we do is a inlay PCL technique, and that is the reason our graft of choice is a quadriceps tendon with a bone plug, with a patellar bone plug, because we find it easy to fix it posteriorly in tibia with a 4.5 or 4 millimeter screw. And on the femoral side, then it is easy for us to fix it with the help of a bioabsorbable screw with a screw and a washer on the femur. As far as the fibulocollateral ligament and the lateral sided reconstructions are concerned, there we depend mostly, we do the Larson's reconstruction with the help of a semitendinosus graft. So we do mostly we will choose for the Larson's. But in case of hyperlax individuals, there we would like to do the Laparade, and along with that the plication of the posterior capsule, posterolateral capsule. As far as the medial collateral ligament is concerned, that is really tricky. In acute injuries, I will not touch it. If I get a chance, I will repair it. The femoral sided avulsions have a better prognosis compared to that of the tibial avulsions on the medial side, and it is really very difficult to reconstruct this graft. Given a choice, I would like to use an allograft, a tendoachilles allograft, because that graft is relatively thicker and broader for use for medial collateral ligament reconstructions. That is what is our experience. But since we do not have much of access to the allografts, in case of delayed reconstruction, if any, for the medial collateral ligament, we use the technique described by Laparade for the medial collateral ligament reconstruction, where we do a superficial and deep reconstruction and plicate the posterior capsule. The diameter, obviously, for the medial and lateral side, because you are using a semitendinosus autograft, on the medial side it is an issue. For the lateral side, it works well. And I think the 4 millimeter or so, or say 3 millimeter diameter of the semitendinosus tendon.
You think cost is an issue in the selection of the type of graft?
Yeah.
Do you think cost is an issue when you select the type of graft, or depending on the type
allograft? You're talking about allograft?
Yeah.
See, as far as the allograft is concerned, we do not have an experience with the allograft. We do not have an access to it, and our patients don't afford the allograft. Unfortunately, the tissue banking services in JIPMER, they are still in the stage of developing, and we are not very well as far as the processing of the allografts is concerned. So much of our practice and cases are with the autografts. So I described what are my graft options, autograft options in case of posteromedial and posterolateral corner reconstructions.
Yeah. Dr. Sandeep, is there evidence regarding quadriceps tendon rupture after quadriceps harvest?
After quadriceps, yes, there is. I think mostly limited to the case series or case reports. But obviously, unsightly cosmetic deformity in the region of the quadriceps has been documented, but there is no much effect on the functional outcomes with that cosmetic deformity. But mostly limited to case reports.
Okay. So we don't have incident rates of quadriceps tendon rupture after quadriceps tendon graft harvest. So that means that the incident is very less, especially because we have only case reports. Okay, Dr. Srinivas, you have any questions?
There's one question here from the viewers. Dr. Bezuardo has asked, what is your graft choice for MCL reconstruction? in multi-ligament injury and fixation choice that you have answered, isn't it?
Yeah.
And also best fixation for quadriceps tendon that you have done, and extensor lag and tendon rupture as a complication later.
For the quadriceps tendon, is that that is directed to me? Yeah. So as I said, in quadriceps tendon, I will recommend using because of our the patients which we have studied, we use a metallic interference screw like the bone patellar tendon bone. So we will not take the partial thickness or full thickness quadriceps tendon alone. We will harvest it with the bone plug from the patellar side, and then we fix it with the help of a metallic interference screw on the femoral side. On the tibial side, and the fixation choices, as I said, we always do double fixations. We do a screw with a washer post and a bioabsorbable screw on the tibial side, because that part of the tendon is relatively soft. We don't use a metallic interference screw. As far as the medial collateral ligament reconstructions are concerned, because we do not have much of or any experience with the allograft reconstructions, if at all I have to do a medial collateral ligament reconstruction, I will first image and find out where the medial collateral ligament is injured, and if it is amenable to repair, I will repair the medial collateral ligament. And if I have repaired, after a repair, I'll reinforce and protect it with the help of a semitendinosus Laparade type of reconstruction. That is reconstructing the superficial and the deep part of the medial collateral ligament.
And regarding, just one comment actually, just regarding bone tendon bone graft, one method, one technique to avoid a longer graft is to measure the length of your graft and then use a longer tibial tunnel. Do you soak the tendons in antibiotics?
Yeah, that's routine. That's routine for us to use. We use gentamicin for routinely soaking the graft. So that's like I will say, an antibiotic impregnated graft. And I think there is an evidence on record to suggest the risk of infection and septic arthritis in antibiotic soaked graft. The incidence is there is a significant difference between use versus not use of antibiotics. So we routinely do it.
Yes, yeah, we also had the author of the paper having a presentation here with us previously, Dr. Figuera. They have proven that vancomycin circage of graft has brought down the infection rates very well. Okay, yeah, Dr. Raghavan.
Yeah, so regarding your use of gentamicin, how much milligram do you use? Like 80 milligram, dilute it with saline and use it, or what do you do normally?
We'll dilute it with saline, and then subsequently we'll use it. We'll not use it as such, but we dilute it with saline.
Okay. Dr. Srinath, do you have any other questions?
There's an issue of managing short bone tendon bone graft. Any experience, any thing with that? If you end up with a shorter graft, I think one way just for the benefit of the viewers, I think is to use the screw, protrude it slightly into the joint, and you remove it later after say 3 months or so. There's one question which has just come up. How do you manage BTV with tibial side plug totally coming out after feeding the graft? I think that's what Dr. Sandeep had mentioned. You can remove the plug completely, isn't it? And then put a interference loop, fixing just the tendon part.
I think his question must be graft has recessed into the tibial tunnel, how to retrieve it back. And then, so for that, what I'll say is that when you are passing the sutures through the tibial side, it is always safer and better. Those who are doing less volumes, it is always safer and better to pass a couple of sutures through the tendinous part of the patellar tendon, and keeping a tail of it, and because that is really helpful in case of such an incident, and those who are doing it infrequently. But as I mentioned, that different methods are available. One is if there is a mismatch, then what you can do is that you can take out the plug and then fix it separately with the help of a screw, or you can pass the sutures through the tendinous portion of the patellar tendon, suture it, and then subsequently use a screw with a washer post with a screw.
Yeah, what he means was the
If it has
plug completely coming out of the tunnel.
Yeah.
Yeah, I think that answers the question. I just want to share some of the feedback.
Yeah, feedback.
So there's a lot of people thanking you for a wonderful presentation.
Thank you. Thank you.
Dr. Vivek Yadav, Dr. Deepas Das. So all of them have thanked for a wonderful presentation. Okay, I think that was a wonderful session. We discussed most of the issues surrounding graft harvest and graft preparation, and also the fixation options, and also the multiple graft choices for a multi-ligament knee injury patient, and the minimum graft size that would be required for a good stable fixation. I think that was a wonderful session. Thank you very much, Dr. Sandeep. Thank you, Dr. Raghavan and Dr. Srinivas.
Thank you. Thank you. Thank you to all of you.
Thank you. It was a very, very nice presentation.
Thank you.
Yeah,
Thank you.
and the evidences you have shown are very good, wonderful. Thank you very much. See you soon.
Okay. See
Take
you
care.
guys. Bye-bye. Bye.